Welcome back. To complete our discussion on the healthcare reform, joining me again is Dr. Gerald Clancy, president of the University of Oklahoma, Tulsa campus, Schusterman Center. Said it a little bit differently, then kind of mix it up here because I'm still a little bit confused about healthcare reform, but you're doing a wonderful job of helping us to break it down and to understand. In the unknowns, I do want to mention this other factor you talked about, clinicians. That was an area of unknowns. Like I said, we talk about insurance. We don't know too much about the quality of care, the care quality portion you talked about. The clinicians, how are they addressed? Because in our first segment, you mentioned the massive shortage, especially with the baby boomers and people living younger, living older, and they're living longer. What about the clinician focus? Who's taking care of us?
Well, the health reform bill really tries to hit it at two levels. The first level they try to hit it is actually expanding the medical education, health education systems that we have. So there is strong language around expanding resident education.
Okay.
So after you've graduated medical school, you get your specialty training, and they would like to expand residency programs. So we are graduating more or more physicians ready to jump into the field, not just from med school, but from the residency training.
Okay.
That is very strongly aligned toward primary care, because the belief is the primary care physician can really take care of many things. They have multiple talents, and so the more primary care physicians we graduate, the more they can extend care to those with mental illness, the more they can do some general obstetrics, the more that they can take care of some kids. So a family medicine physician really can do many things at once. So
let me ask this, because you just mentioned something that people might be a little confused about, the primary care physician, family practitioner. How does that person differ from the general practitioner? Many people still know about the general practitioner in terms of the physician. Is this just other terms for them, or?
Well, the GP term really used to refer to someone who had done just a year's worth of general residency training. So they've done 4 years of med school and then done a year internship, and they're kind of a general practitioner. They're generally trained. Family medicine is a formal residency program, 3 years long at a minimum, and they actually can do additional years in fellowship. They are trained in really all aspects of family care, from general obstetrics to pediatrics to adolescent medicine to adult medicine to geriatric medicine. So they can provide primary care to the entire age spectrum is what they can do. Now they need to heavily rely on specialists for patients with complicated issues. So they rely on psychiatrists, they rely on obstetricians, they rely on geriatricians when they need to. But the belief is, if we have more primary care physicians out there, we can extend that care pretty far.
Okay, and then the focus becomes more so on prevention versus dealing always with chronicity, because you're hoping to not have people progress to that level.
Exactly. The hope is you have an established relationship with a physician or a nurse practitioner or a physician assistant that you're going to have a relationship with and work on things before they become bad. So I have colon cancer running in my family. I work with my primary care physician now to make sure that I'm not someone who gets caught off guard as far as being at risk for colon cancer.
Okay.
It is a perfect example.
Excellent.
Within the health reform bill, there's support of expanding nurse practitioners, physician assistants, public health as well. So there's a big push of expanding the workforce in the first place. That's one strategy. The second strategy, they believe, is we're not going to be able to go fast enough in that arena as far as expanding the workforce to still meet the needs. So how can we deliver care differently? And there's a big push toward what we call team-based care, that a physician and a nurse and a social worker and a pharmacist and a physician assistant, nurse practitioner all work together as teams and have a group of patients, maybe 1,000 or 2,000 patients, that are the responsibility of the team. And whatever that patient needs, from pharmacy to social services and case management to physician care to basic primary care, the right team member is intervening for that patient. And when you come into that clinic, you actually know the entire team. And so I use myself as an example. If I had a question specifically about my medication, and was there a problem with my medication that I was worried might interact with another medication, I could actually rely on the pharmacist rather than having to call the physician on that one. If we were having some family troubles and really I needed somebody to help coordinate care for one of my children, I wouldn't need to rely on the physician to do that. I can have a social work case manager or a nurse case manager
Okay.
help me with that. And the idea is everyone practices at their top of their license. They get to use their maximum training to do the most for them.
And that really is a change in how we kind of look at healthcare and approaching people today, because you go to the physician over here and then you go over the pharmacist over there. But
Right.
like you said, this is a team-based kind of facility that is being encouraged.
And we've got about 2 years under our belt in doing this in primary care. It's called the patient-centered medical home team model.
Okay.
And we've done that, and what we're finding out is the patients are happier because they do have access to the right healthcare clinician on the team for the right problem. The clinicians are much happier. They feel like they're getting things done for the patients
Right.
rather than being frustrated with fragmentation of communication and getting things done for the patients. They see things getting done for the patients, so they're much happier, and the outcomes for the patients are
Just the
much better.
compliance would be much greater.
Yes.
Let me ask in our last couple minutes together here about how is this going to impact universities such as the University of Oklahoma, universities all over our nation, in terms of preparation, and even universities such as yours that do operate, first class clinic facilities. How is this going to impact? What are you doing?
Oh, we're doing an awful lot. We feel like we're pretty well positioned. Our change from University of Oklahoma College of Medicine Tulsa to School of Community Medicine was really in preparation for this. We saw
Okay.
this coming, and we really wanted to be community oriented around that. Um, the things that we will be doing, we will be expanding our health education programs from nursing to physician assistant to nurse practitioner
Okay.
to physician graduate. So we're going to be part of that. We're up to our ears in team-based care. We already do it in primary care. We've done it with psychiatric service as well. We have our impact outreach team that is a special mental health team that provides services to those with severe mental illness. We've got a palliative care team over at St. John, and they do great care with end-of-life issues in patients with severe and terminal illnesses. We've got a geriatrics team as well. So a lot of
Okay.
these things we're already doing, and we're finding them to be quite helpful. We've really played a major part nationally with health information technologies as well, and we've received a large grant from the federal government called the Beacon Communities Grant, which is really around Tulsa working together as a community using health information technologies to actually improve the quality and access to care.
Okay.
And that's a pretty high bar, but we're into that as well.
And I'm going to interview in another show David Kendrick,
Yes.
who is a part of that, to tell us what it's all about. Well,
Great.
Jake is telling me I am so much out of time. Thank you so much for helping us understand a little bit better about healthcare reform and what the components are and what the university is already doing and other universities across the nation to prepare and help us out. And thank you so much for reading that 2,000-something pages. Well, that's our show. For Health Alert, I'm Pam Butler. I'd love to hear your questions, comments, or suggestions for future shows. Please write me at Health Alert USA, P.O. Box 50913, Tulsa, Oklahoma 74150. Or if you're on the email trail, please email me at healthalertusa@gmail.com. And don't forget to visit me on YouTube at youtube.com/healthalertusa. Take care, and remember, healthcare reform is going to be a wonderful thing for us all because the quality of care is going up, the accessibility. It's a win-win proposition. Take care. This program would not be possible without the support of OU Physicians in Tulsa.